endoscopic ultrasound-guided pancreaticogastrostomy to facilitate retrieval of a proximally migrated pancreatic duct stent in a post-Whipple patient. Proximal migration of pancreatic duct stents can occur in 5% of cases. Failure of stent retrieval is associated with pancreatitis, bleeding, duct disruption, stent fracture, and occlusion. Therefore, prompt retrieval of the stent is necessary, though it is challenging due to the narrow diameter and complex path of the pancreatic duct. In this case, we present a staged approach for the retrieval of a proximally migrated pancreatic duct stent in a post-Whipple patient with a pancreatico-jejunal anastomotic stricture. We present a case of a 70-year-old male with history of pancreatic acinar cell carcinoma who had undergone Whipple surgery and had several presentations with recurrent episodes of acute pancreatitis. CT scan with IV contrast revealed dilation of the main pancreatic duct to 6 mm upstream of the pancreatico-jejunal anastomosis. Enteroscopy-assisted ERCP was attempted, but we were unable to locate the pancreatico-jejunal anastomosis. Endoscopic ultrasound demonstrated dilation of the main pancreatic duct to 4.7 mm proximal to the PJ anastomosis, tapering to 2 mm in the distal pancreatic body. A hyperechoic round structure was identified within the duct, consistent with the migrated pancreatic stent. EUS-guided pancreaticogastrostomy was performed with placement of a 7 French 15 cm straight plastic pancreatic stent crossing the pancreaticogastric and pancreatico-jejunal anastomosis. The plastic pancreatic stent was then upsized to an 8 mm by 60 mm fully covered self-expanding metal stent through the pancreaticogastrostomy tract to further dilate the tract for stent retrieval. Here we present a pictorial representation of the patient's anatomy and the migrated pancreatic stent in relation to the pancreaticogastrostomy stent. This video demonstrates our approach to removal of the migrated pancreatic duct stent after stage dilation of the pancreaticogastrostomy site. The fully covered self-expanding metal stent was removed from the pancreaticogastrostomy site. A sphincterotome preloaded with a guide wire was used to cannulate the pancreaticogastrostomy site, and guide wire was advanced into the pancreatic duct past the pancreatico-jejunal anastomosis. A cholangioscope was then advanced over the guide wire. The pancreatico-jejunal anastomotic stricture was noted. As the cholangioscope was removed, we noted the migrated pancreatic stent. The stent was grasped with cholangioscopic forceps and removed completely from the pancreatic duct through the scope. The stent was confirmed to be completely intact. The pancreaticogastrostomy site was cannulated again and guide wire left in place across the PJ anastomosis. The PJ anastomotic stricture was then dilated with a balloon dilator. A plastic pancreatic stent was then advanced over the guide wire and placed crossing both the pancreatico-jejunal and pancreaticogastric anastomosis sites. In follow-up, the patient remains asymptomatic without recurrent episodes of abdominal pain or pancreatitis and is scheduled to follow up for an ERCP for stent upsizing to treat the pancreaticogestional anastomotic stricture. In summary, stepwise dilation and stenting via EUS-guided pancreaticogastrostomy is an effective approach for facilitating pancreatoscopy and retrieval of a proximally migrated pancreatic duct stent, especially in patients with altered anatomy.